Hello, everyone. Welcome back to Luncheon with the Experts, a Carcinoid Cancer Foundation program brought to you by Ipsen Biopharmaceuticals. My name is Rain Bennett. I am your host this week and every week, and I am a filmmaker and a writer, a few other things, but those are my primary roles in the position that I have been in working with alongside CCF for 10 years, maybe actually going on 11 now. Long time that we've been working together, one of the most fulfilling parts of my career, sincerely. And during that span, during those 10 years, we have created countless, hundreds, in fact, videos of different kinds, the live video series like the one you're going to watch today, documentary style patient stories, highly produced treatment-based videos, all over the spectrum, but all with the same mission in mind, folks, and that is to spread awareness and education about neuroendocrine tumors. That is what we are here to do. Now, the show you're going to watch today is kind of a Q&A session where you can have an interactive one-on-one session with an expert in the field. And I think that the real value that we bring in this show is twofold. It is one, the information and answers to your question that you will get from our guest today, and two, the community that we've cultivated here within the show. And so you'll see people chiming in from that community in the comments section there, and many of them are already telling us hello and where they're from. Always have a great representation from Mexico, our friends from Net Mexico, always a good representation from Canada. And in fact, we have people from all over the world. So if you're new to this journey, new to this show, I want to say welcome. Take some time and introduce yourself to the community. Tell us where you're from. I promise you this community will embrace you and help you along this journey. So before we get started, we always want to thank our sponsor, Ipsen Biopharmaceuticals, for their support of Luncheon with the Experts. We wouldn't be able to do the show without them. And we always have this disclaimer from them, and that is that the opinions expressed today by our guest presenters, as well as the questions that you all, the audience, have asked at home, haven't been created or suggested ahead of time by the sponsors of Luncheon with the Experts. And CCF doesn't endorse or promote any of the views, opinions, or information that will be provided in the presentation. Audience members should not rely solely on the opinions or information expressed today by the guest presenter and should seek guidance and direction from their own medical advisors regarding any choices they make about their health or treatments. Okay, that last line is really the takeaway there. We're going to give you some good answers to your question and general advice, but by no means do we or our guests know your specific case. So take those answers, take that advice back to your home team, which does, and make the best plan and path forward for you. So today, I'm very excited to welcome back to the show Dr. Julie Hallet, who we had a great time the last time that we did this, and she is part of a great community that we have a great relationship with, and many of the doctors there have been on the show. Dr. Hallet, how are you today?
I'm very good today. Thanks for inviting me back. How are you doing?
I'm doing well. Absolutely. We would invite you back. We had a great time last time. I know the people were excited. I've seen the comments on our earlier post when we were announcing the show this week. So people are excited about it. But for those who may not be familiar with you already, tell us a little bit about who you are, what you do, the institution that I alluded to, and the way I like to word it is the role that you fill in this net community.
Yeah, so I'm a surgeon. I'm a surgeon specializing in cancer. And within cancer surgery, I specialize even more specifically in neuroendocrine tumor, and in particular in surgery of the intestine, the liver, and the pancreas. Mm-hmm. And I would say probably about a third of my practice is dedicated solely to neuroendocrine tumors. And I'm very lucky to be part of a multidisciplinary team at Sunnybrook, which is one of the largest academic hospitals in Toronto, Ontario. So that's in Canada. And we have a multidisciplinary clinic where we combine surgical oncology, which is what I do, medical oncology, radiation oncology, and endocrinology under the same roof and under the same clinic to treat patients with neuroendocrine tumor with like a truly interdisciplinary approach. And so because of that, we have a very high volume of people diagnosed with neuroendocrine tumor and that we get to treat every year. And then the other side of the work that I do is more related to research. And in particular, what I like to focus on with neuroendocrine tumor is understanding the access to care component. So how do people get access to care? Because we can have the best treatments ever possible. If nobody has the opportunity of getting those treatments, then they're not helpful. So what I'm really looking at is how do we get people access to treatments and to quality treatments in the best way possible? and also integrating into that so the patient reported outcome and the patient experience, and how does that all interplay together to ensure the best quality care possible.
The three types of oncology again were surgical, medical, and what was the third?
Radiation oncology. So that's doctors who will deliver radiation therapy. And so the unique thing about our group is that prRT, which I think a lot of people are familiar with now, is actually delivered by radiation doctors and not by nuclear medicine doctors. Because the PRT is sort of, this hybrid therapy that uses both radiation and a nuclear medicine technique to deliver that radiation into the tumor. So the way that we build that program is with the radiation specialists delivering it.
Got it. Thank you so much. So anything, and you're comfortable taking questions of really any topic, right? Even though surgery is kind of your main focus.
Yeah, I'll do my best. If I if I don't know, I really truly have no idea, and I'll just mention it. So I hope that's okay with everybody.
Yeah, no, I think it will be. Everybody's very forgiving here, but I wanted to establish kind of where your expertise lie, because we get questions about surgery obviously every week. So I think that we will have no problem staying in that zone. But folks, you heard it from Dr. Hallet. No question is out of bounds. So go ahead and start sending in those questions. We're going to try our best to get to all of them. I promise you, we will not get to all of them because you all have so many good questions every week. That's kind of a good problem, because one, it allows us to keep doing the show every week because there are lots of questions that we have to answer, but that's what we're here to do. But I will say that if we don't get to it, or if the answer we give you creates a follow-up question, which often it does, and we don't have time to get to that, follow up with CCF after the show. You can message them here on Facebook. You can also visit their website, carcinoid.org, and I promise you they'll do everything they can to get you that information. A couple rules of the game before we continue on. We can't really take, Dr. Hallet can't really field two very case specific questions. Okay. So a lot of times people will want to give all the information about their case thinking that will help, and we simply just can't address those. So try to pose your questions in a generic form. We'll still try to get to them. And sometimes we'll ask you for more clarification if it's too vague. So try to answer, or ask rather, in a broad sense so that we can give you general direction, but just knowing that Dr. Hallet, if she is not your specific doctor, is going to be really hard to know all the ins and outs of your specific case. A couple of things I like to ask you all to do. We have great numbers already, which is exciting because we're only a few minutes into the show. We always want to get as many people here as possible. As soon as the show's done, it's going to be posted evergreen permanently under the videos tab on Facebook. Starting next week, it'll be on YouTube. So people can watch the replay. If they missed today, you can watch the replay if you need to rewatch it. But the real value is being here and getting a question across. So if you know someone that's not here that needs some reminding, go ahead and tag them in the comments. Let them know the show is going on. And then secondly, if you see a comment or a question rather in the comment section in the sidebar that you also have or interested in the answer to, you can like that just under the question. There's the option to reply to that or like it, love it, whatever the motion you want to use. They all work the same way for me, which is to effectively upvote that question. And I'll know that it's important to get that across. All right, go ahead and start sending your questions. We're going to start fielding them. Before we do, Michaela says, love the zebra shirt, Dr. Hallet. I guess that was probably intentional. I love it too. Somewhere around here, there's a zebra that I have as well. So always love everybody. Oh,
is there? Well, that's a great thing with working with neuroendocrine tumors. I get to grow my zebra wardrobe.
Exactly. With no shame, right? Yeah, I love the icon, and I really love to see, doctors, especially when you enter their offices, kind of having that, because to me it shows. I don't know. I say this every week. People might get tired of it, but like the community is so strong in this net world, and the support, not just, from people like you, it's clear to me, it's not just a job. People are entering this for a certain reason. And just from what you alluded to earlier with your focus on access to care and things like that, like, I know that it runs deeper for you. And I think that really is kind of, the way it is across the board in that community, from what I can tell. A lot of people really support it, and I really love to see that. But enough about my perspective on things. Let's start taking some questions. The first one comes in from Lynn. Lynn says PNETs with metastases to liver. That's her case. Am I right that cancer cells travel through the blood vessels? And if so, do the cancer cells travel better due to a long warm bath, presuming that heat enlarges the blood vessels, thus helping to promote metastasis?
Yeah, that's a good question, Lynn, about how the metastases happen and whether there's anything that people are doing that can facilitate the metastases. In reality, there is very little that people do that will change how the cancer behave, other than cancer treatments, that is. So yes, what happens is the cancer cells will leave the primary cancer, so in this case, the tumor that's sitting in the pancreas, and then they will get out of there in two ways. They can get through lymph nodes, so through what we call the lymphatic system, or they can get through the blood vessels. And then from the blood vessels, they will get disseminated to other organs. In neuroendocrine tumors, because a lot of them come from the intestine or the pancreas, the first really is often the liver, because all the blood that comes from those organs is sort of filtered through the liver before going back to the heart and completing that circulation. And however, what we're doing to our body, or like having warm bath or anything that could dilate the blood vessels, is not known to actually have an impact on that. It's not necessarily the amount of blood flow that has an impact on how the cancer cells will spread or distribute. It's really just how the cancer is behaving. So, those things don't truly impact the cancer spread or the cancer journey. And I know there is a lot of things out there, and I guess that's more of a general sort of message. There's a lot of things out there that are saying, this or that may promote cancer growth, or this or that will make your cancer worse. And that can have to do with diet, with lifestyle, with, simple things as taking a warm bath. And there is very little that we actually know about these things. Most of these things, we don't know if they have an impact, and most likely they do not. And so what I tend to tell my patients is, if that's something that makes you happy to take a warm bath with like bubbles at the end of a long day, then don't stop yourself. Just go ahead. The most important thing is that you feel good in your body and in what you're doing. And that has a much more direct impact on how you're going to feel and how you're going to go through treatments and through the cancer journey, than all those other things that we see on different platforms. I hope that makes sense.
Yeah, I think it does. And let us know if you have any other questions. But I have a kind of a follow-up question from someone else in that same vein. This is a common one from KR. Are nets fed by sugar? Now, I'm a documentary filmmaker. I know there are tons of films and articles making claims like this, and it's a question that gets commonly asked. So your thoughts. So you had already alluded to diet as one of those things that people think may influence cancer growth.
So the short answer is no. We don't know that it is fed by sugar. We do not know that cancer is fed by sugar. And I think that that's one of the most common myth, as you alluded to, Rain, that is going around. And I find that because of that, a lot of people will limit themselves in what they eat and get to like very, very restrictive diets, when in reality, it doesn't change how the cancer is behaving. It doesn't change how the cancer is responding to therapy, but it does change how people are living. And it can, some people start feeling very miserable because they're barely eating anything to make sure that they can control every single variable, when we don't know that it has an impact. So again, my message is always do what makes you happy and what makes you feel good. And then from there, that's how you're going to get through your cancer journey. That's how you're going to get through your treatments. That's the most important thing. Things like that, we don't know, makes a difference, really. There was recently on Twitter, there was a very interesting thread about that, where somebody really debunked all the arguments about the sugar and cancer. I'd have to find it again. I can post it or send it to the foundation. If I can.
If you do,
check it back.
I know we follow each other too. Tag me in that. I'd be interested to see that, because, as I said, I see that all the time. And I wonder, you may not know the answer to this, but often those narratives get created from like the misreading or misrepresentation of data of a study that was done. Do you know the origin of that narrative? It might be a bunch of things kind of, culminating in one narrative.
Yeah.
But was there a study that came from that has been misread or that you know of?
I don't know. I don't know about studies. I think it might come from some principles. So, all the cells in our body will use sugar to grow and to renew themselves. That's just a normal process, right? That's why
Right.
we're eating. It's to feed our body so that the cells get fed, get functioning, and then can renew themselves and duplicate. And what we know is that cancer cells duplicate faster, right? They grow faster. One cell will become 2, 4, 8, etc., at a faster rate than normal cells. That's why tumors grow so fast. And of course, if a cell is growing faster, to do so, it's going to use more sugar. So I suspect that there might be something coming from there. This particularity of cancer cells is actually something we use in cancer imaging. So some of the PET scans that are done, not the ones for neuroendocrine tumors, but some of the PET scans, such as FDG PET scans that are done for more traditional cancers that grow faster, are based on that. What we are doing is like sort of seeing where are there areas in the body where cells are using more sugar, and that will usually show up where the cancer is, because the normal cells don't use that high rate of sugar. And I think maybe from there, some people have then decided to study or infer that if you eat sugar, you're feeding the cancer cells. That's not necessarily the case. Cancer cells use sugar to grow. It doesn't mean that eating sugar feeds them.
Okay. Got it. Thank you. I appreciate you taking the time for that. Next question from Marge. So thrilled to see a Canadian net specialist. So are we, Marge. Okay, so this is a question that's perfect for your focus on access to care. Marge says, what can those of us in Ontario do who don't have a net specialist and aren't part of the health areas in Toronto? I had a gallium at PM. I'm not sure what PM is, but you probably are. At the start of my diagnosis, and was told that I could only access once in a lifetime. Is there an option in Ontario for second opinions or better access to scans and services?
So that's a very good question. That's something that we work on every day. So I think I would separate the question in two parts. The first one is access to services and second opinions, and the second one is access to scans, because they don't necessarily go together. In terms of access to neuroendocrine specialists, and I think that is true in different jurisdictions, not only in Ontario. Even if you don't have a neuroendocrine specialist close to you, you can always request a referral or another opinion from neuroendocrine specialists in specialized like tertiary or quaternary centers. And I think these days, with all the virtual care that we are using, this is much facilitated by that, because we're able to do virtual consultations, like, review charts and talk to patients on the phone or on video. And that allows us to make an assessment and then provide recommendation and sort of support the care without having people travel like thousands of kilometers and take hours of or days of their week to do that. So that is totally feasible. And we tried at our center, and I know others do it as well, to work with what we call the shared care model, which means that we do realize that not everybody can come to Toronto all the time or to the major city near you. And we also don't have the ability to treat everybody in Ontario with a neuroendocrine tumor, because we're just a few people and we're limited in the number of people we can see. But what we can do is partner with oncologists in different communities around Ontario and care that way. So that means that you don't necessarily see us every single time. But when there's crucial moments, like if the tumor is progressing, if the symptoms are changing and your doctor needs guidance, then they can reach out to us and then we can provide that guidance. At Sunnybrook, we also have currently a tumor board where other doctors from different regions of Ontario can call in. And that way they can present their cases and get opinions or guidance from the different cancer doctors that are sitting on that tumor board, and that happens once a week. So there's ways to do it like that, and you can most definitely get a referral for another opinion. With regards to the scans, that is a very specific thing to Ontario, so I'll just go over this more quickly perhaps. It's the way that things are funded. So in Canada with public healthcare, there's a lot of things that are authorized and not authorized, meaning it's authorized. If it's authorized, the government will pay for it. If it's not authorized, they will not. And as a healthcare institution, we cannot provide care that is not paid for. That's just how this system works. And the way Ontario has decided to manage gallium scans is that you can get one, either for staging, so to see how much tumor there is when someone is diagnosed at the beginning, or to identify a primary tumor for diagnosis at the very beginning. And then it is not authorized for repeat usage, for follow-up surveillance or reassessment, for example. And right now, the Ministry of Health in Ontario has also decided, despite a lot of representation and work from our teams, that all those scans will be done at Princess Margaret Hospital, so that's PM, in Toronto. So even though we have the ability to do those scans at Sunnybrook, for example, we are not authorized to do them because they will not be covered. So that's the issue right now. So that's why I'm saying that access to specialized opinion and the scans is different. Because you come to see a specialized neuroendocrine doctor doesn't mean you can get easier access to scans, because those are limited by government funding and regulations.
Got it. Thank you. So listen, if I read every comment, we always have a good representation from Canada on the show, but if I read every comment today that was shouting out Canada loud and proud, we'd be here all day just reading those. So I'll cover it in one time. Like, the country is showing up today and they're very excited that you are here. So one more specific Canada question, Toronto based. Anne-Marie says, is Sunnybrook and UHN, University Health Network, part of the same tumor board?
That's an interesting question, Anne-Marie. So we're not the same institution. We function as separate teams. So the team at Sunnybrook is one of the largest centers in Canada, seeing neuroendocrine tumors. And what exists is there's a mechanism that is a provincial tumor board, meaning that every month there is a forum where anybody in Ontario can present cases, and all the hospitals in Ontario are there to provide input and to discuss together. So that mechanism exists. At Sunnybrook, we also have our own tumor board because our volume of patient is so high that we couldn't function only with a provincial one. And there was much more demand to have more regular meetings. So we have our own tumor board, but then once in a while, we'll also participate in a provincial one. I hope that answers the question.
Got it. I think so. Anne-Marie, let me know if you have a follow-up to that. Next question. Let's talk about surgery. You know a thing or two about that. From Jennifer, I have a 3-centimeter tumor in my duodenum, then it has spread to inoperable lymph nodes. So would surgery be beneficial to me? How rough? And then the second question is, how rough is the surgery and what are long-term effects of it?
That's a good question. It's all the good questions to ask for when thinking about surgery. That depends a lot on what the tumor looks like and where it is located in the duodenum. The duodenum is a short organ, but it has like sort of 3 different parts that are very different. If it's in the first part of the duodenum or the third part, it's easier to remove. When it's in the second part, it's much more difficult because it will be attached to the pancreas and will be attached to where the bile duct joins the pancreas and the intestine. So that requires a much more extensive operation. So if it has, in general, the way we approach tumors at a duodenum is if they are localized, so there is no other disease, so no metastatic lymph nodes or no metastatic spread to the liver or other organs, then we tend to go ahead and remove them. If there is other disease, so either in lymph nodes that are far away from the tumor or in other organs like the liver or the lungs, for example, then typically we won't necessarily remove it because at that point, removing it will not change how the cancer is behaving. And if anything, doing surgery will actually stop the time where you're taking medication, because you cannot take those medications around time of surgery. And those medications is what is needed to treat the spread. So it really depends on where it is located and the primary tumor in the duodenum, and then where those lymph nodes are and how big they are.
Got it. Thank you. Folks, if you just joined us or joined us a little bit late, this is Luncheon with the Experts, the Carcinoid Cancer Foundation program. And today our guest is Dr. Julie Hallet from Sunnybrook in Toronto. Lots of Canada in the house, as we've already said. And as soon as I said that last time, a lot of hearts fluttered in through the Facebook page, which unfortunately you can't see, but it was a lovely sight. Next question from Marcellus. Can tumors cause a lack of appetite? So much so that you become severely malnourished? And if so, can the excision of tumors help gain that appetite back?
Oh, that's a loaded question. There's so many things to have to say about this.
Indeed.
So a short answer is yes. The long answer is there's several mechanisms through which it can do that. Okay. So, just cancer itself, especially when there's a higher burden of cancer, so a lot of tumors, can reduce appetite. And we see that in all types of cancers, like not only neuroendocrine tumors. And one of the reasons we think that happens is because cancer cells, and going back to what we talked about before, because they grow much faster than your normal cells, they try to suck up energy, right? And so because all your energy goes towards growing that cancer, not voluntarily, I acknowledge that, then you have less energy and people will feel like, crap, pardon my French here. And that includes having lower appetite. So that's one of the things. The other reasons, particular to neuroendocrine tumor, where appetite can be reduced and that can lead to severe malnutrition, is number one, endocrine symptoms, so secretion of hormones, or number two, intestinal blockages. So for the first part, both pancreas and small intestine neuroendocrine tumor, as a lot of you may know, can produce hormones, and those hormones have a variety of consequences on your body. But one of them can be to reduce your appetite or to change the way that your body processes food. So either that it's going to make more use of the energy that comes from food, or it's going to use it differently. And so because of that, appetite can be reduced, but also everything you're eating is processed differently, and that can lead to malnutrition. So that's the one aspect. The second aspect is some people that have tumors in the small intestine in particular may experience blockages. And sometimes those blockages will sort of happen over the course of years. I'm talking 5, 10, 15 years. And you get used to them, so you don't necessarily feel the pain anymore, or you don't notice the pain, but it's still there and your body gets used to that. And so the way that people cope with it over time is by eating less. And that can also have consequences of how your body gets nourished. So there's multiple aspects to it. So yes, it can happen. If it does happen, then the important thing is to talk with your doctor and try to elucidate which one of those mechanisms is responsible for it, because they will require different treatments.
Got it. Thank you. So we have two very similar questions. I will read the one from our friends on the southern border, Nets Mexico, but also Karen had a very similar question. And it is that Nets Mexico says, we've been hearing about patients with other types of cancer being treated with a high intensity focused ultrasound. And I think this is something kind of new. And so the question is this something that could be used to treat neuroendocrine tumors?
And that's a good question. So high intensity focused ultrasound, also known as HIFU, sounds very fancy, is one new, what we call local ablation therapy. And what it does is that it will use the name says it, but very high ultrasound frequencies focused on a tumor to sort of kill it or burn it in some ways. That's the short version of it. And it's been studied in a number of cancers, and Sunnybrook, not myself, but a lot of other doctors here and researchers, is a leader in that field. Okay. But right now it hasn't been used for neuroendocrine tumors. It actually isn't used frequently for a lot of cancers. It's still very much investigational. Okay. Our team right now, for example, is going to start using it as part of a clinical trial for pancreas cancers. So pancreas cancers that cannot be removed with surgery because they're too extensive. We're going to be trialing it on it. I know it's been used for prostate cancer and for some bone lesions as well by the teams at Sunnybrook, but it's not currently, at least to my knowledge, sort of standard of care. It's only investigational, and we haven't looked at it for neuroendocrine tumors. One thing that we need to know for neuroendocrine tumors is that those tumors are slower growing. So they're not as responsive to treatments that like radiation therapy or like HIFU. It doesn't mean that they are not. They can still respond. but they don't respond in the same ways. So this means that once those treatments are actually accepted and are a more common practice, they will have to be tested specifically on neuroendocrine tumors to know if they have an effect.
Got it. Thank you. Hopefully that helps answer the questions. But and for folks that didn't catch that, that was HIFU, HIFU, high intensity focused ultrasound. So yeah, look into that. Next question from Deanna. I had an octreotide scan a year ago after surgery to remove a net and a dermoid cyst on the ovary. And now I'm being followed with ultrasound and MRI. Would a gallium scan be helpful at some point?
So that would depend, I'd say, on the type of neuroendocrine tumor. What we see in ovaries, there can be like sort of what I would say true neuroendocrine tumors within the ovary. Or sometimes there's also what we call a differentiation of neuroendocrine tumor. So this means that there is another type of tumor, and that tumor has features that looks like a neuroendocrine, but it's not a neuroendocrine tumor per se. So assuming that this is a true neuroendocrine tumor on its own that was sitting there, once it is removed and there is nothing else to be seen on ultrasound or MRI or CT scan, the gallium will not add much more. So it's pretty unusual that we would be able to see additional disease if there is nothing to be seen on the conventional scans. And we talked about how difficult it is to get repeat gallium in Ontario. It is also difficult in other jurisdictions, but for different reasons, which is mostly related to insurance funding. I know I have colleagues in the US that have trouble getting one, and even more trouble getting repeated one. So we try to use gallium in general when we know it's going to make a difference on how patients are treated. So at this point, if there is no other evidence of disease, I think it is very reasonable to continue with just surveillance. And then if something shows up at that point, then maybe gallium can be discussed.
All right. Thank you. Next question. This is another gallium question. So Susan, also in Canada, I've been trying to get a gallium scan for several years. We in Canada were so excited when it finally came to our country, but I know so many people who don't get approved. It is the norm in the US. I was told by my oncologist that it's not getting approved because the results would not change my treatment. I'm seriously thinking about getting a second opinion. Any suggestion on how to get a gallium scan in Ontario?
So it's a bit what I had mentioned before. There are very specific guidelines and conditions under which we can get gallium scans in Ontario. It is currently limited by the Ministry of Health. And just, you know, to be clear, this is the case everywhere. It's easier to access, but it's not completely open to access in other jurisdictions like the US, because there are, again, some indications for it that have to be met for it to be covered by insurance, for example. So, and I think maybe my small or short editorial about gallium is that gallium scan has revolutionized the way that we treat neuroendocrine tumors, how we're able to understand the biology of the tumor, detect additional disease. But I think it's also getting a lot of press, and potentially people are expecting or hoping that gallium can do more than what it can actually do. So gallium scan, and from my perspective, is something that is very useful in a few circumstances. The first one is when we suspect there is a neuroendocrine tumor, but we're not able to prove the diagnosis. That is very helpful because it can confirm it. When we are first assessing somebody with a neuroendocrine tumor and we want to know the exact amount of tumor there is to treat, so we already know there's a neuroendocrine tumor, like for initial what we call staging, so knowing exactly where the tumors are located, that is helpful. And then sometimes it can be helpful for troubleshooting after the initial diagnosis, initial treatment. If we're in a circumstance, for example, where we see a little something on a scan and we're unsure whether it's a neuroendocrine tumor or it's a scar from prior surgery or prior infection or something else, it can help differentiate that and then sort of troubleshoot what we're looking at. But usually we'll do that only if it makes a difference on what we're going to be doing for treatment. If it's not going to change the treatment we're giving, galliums are really cool. They're like beautiful pictures. I really like looking at them, but they may not be that helpful. It might be better in circumstances where we don't have access to it repeatedly to keep it for when it's going to be worth it the most.
Got it. Thank you. From Michelle, what are some reasons why one may not be able to initiate bowel movement after a low anterior resect?
Yeah, that's a very common question after low anterior resection. So there's a lot of different aspects to that. It depends how long after a low anterior resection, depends how low the resection or the new connection is. So the few things I can think of is, the first thing is like simple aspects. So make sure you have enough fibers in your diet, and you can look to have a consultation with a dietitian for this. Some people can also take just medications to help, just because you have, run-of-the-mill constipation. That's always possible. And then there is something that's called anterior resection syndrome that can happen. I'm not an expert at this because I'm not a colorectal surgeon, but that can be it can be related to the way that the rectum was reconstructed, or the way that the connection has healed. And so to assess that, the important thing would be to see your surgeon to have that looked at.
Got it. Thanks, Michelle. Hopefully that helps. From Anne, can lanreotide cause digestive pain and issues?
Yeah, thanks, Michelle. That also is a common question. So lanreotide can create some side effects, especially in the first few days after receiving the injection. And so there can be sort of bowel cramps, or some people will have like loose bowel movements for 1 or 2 days, but usually it subsides after that. And I would say in general, lanreotide is a very, very well tolerated drug. I had patients that are on them for years and tolerated very well. If there is any bowel issues or digestive issues, I'd say before saying it's lanreotide, we can check if it could be related to tumor itself, or if you've had prior surgeries, if there's repercussions from that could explain it. And then identifying that as a side effect from lanreotide would be sort of what we call an exclusion diagnosis. So once you've eliminated everything else, and that's the only thing that's left, it can be related to that.
Got it. So Stan says, I realize, Dr. Hallet, that surgery is your specialty, but do you have any thoughts about the CAPTEM regimen? And let's establish what that is before you field that.
Yeah, so CAPTEM is a type of chemotherapy. It's a combination of 2 drugs, capecitabine and temozolomide. And it's a chemotherapy that is taken as tablets. So you don't need to have like an infusion in your veins like other types of chemotherapy. It's a more, I would say, gentle chemotherapy. And I'm using quotes here because my medical oncology colleagues would say there is no such thing as gentle chemotherapy. And I hear what they mean. Yeah. All chemotherapy has
Hello. Here we are. I think are you hearing me? I'm not hearing you.
Oh, I'm here. I'm here.
There we are. We got you unmuted. Okay. Back at it.
All right. I'm not sure where it stopped.
Let's just continue on, folks. You can let us know in the comments where that fell through, but technology, it happens. Well, we were talking about CAPTEM regimen. I'm going to move on to the next question, but folks, you can let us know and we'll try to pick back up. As it is right now, we've got about 20 minutes left, so we're going to keep taking your questions. Another one from Michelle, back to the gallium scan. Have you seen any false positives on the gallium scan?
Yeah, so false positives can exist and are well described. In particular, for the pancreas, there's an area of the pancreas that is called the uncinate process, or just like sort of a little extension of the pancreas at the back. And in that area in particular, there can be what we call physiologic uptakes, like just normal uptake of octreotide. and that can create false positives in that area. So you always have to be, cognizant of that when we're reading the scans and understanding their meaning.
Got it. So Laura helped us and chimed back in. We were talking about CAPTEM, and you had alluded to it being a gentle chemo, but that your colleagues may criticize you a little bit for that because no chemo is a gentle chemo. So maybe we can back up to there and establishing what that was. You talked about the two drugs. Yeah.
I think the point is that it's the reason I quote as gentle chemo is probably the easiest way to explain it. It's something that is better tolerated and easier to take than other types of intravenous chemotherapy. We use CAPTEM for neuroendocrine tumors for sort of lower grade neuroendocrine tumors. So not the ones that are like super fast growing that we call neuroendocrine carcinoma actually, but for the ones that are sort of in the middle. They're not the slowest growing of them all. So the ones that are like dormant and can be controlled with lanreotide, they're not a super fast growing, they're sort of in the middle. So they need something stronger than lanreotide or octreotide, but not as crazy as those intravenous chemotherapies. So that's where we'll use the CAPTEM for those sort of in the middle types of tumors.
Got it. Thank you. And Stan, hopefully that answered your question. And if you have a follow-up or if it didn't, let us know. From Gwendolyn, if octreotide stops working, what is used in surgery to replace drip and bolus?
I guess that depends what the question relates to, but I suspect to treat carcinoid syndrome during surgery. So if what happens during surgery when there's a lot of hormones being released is that the blood pressure can go very low or very high. And what we'll do is octreotide is one of the drugs that can be used. There's a lot of other drugs that can be used by anesthesiology to control that. And actually there are some hospitals now that conduct surgery for patients with neuroendocrine tumors without any intravenous octreotide. So there's a lot of other alternatives that are safe to use and very effective.
Got it. Thanks, Gwen. Hopefully that helped. From Deanna, what blood work do you order to monitor someone with no evidence of his disease? CGA or chromogranin A? Something more?
So chromogranin A is something we try to part with, so stop using. Reason being that it's not specific, so it's not particular to neuroendocrine tumors. There's a lot of reasons why chromogranin A can go up. I used to tell my patients that if you sneeze real hard, your chromogranin A might go up in the hour following that, and it doesn't mean that there is more neuroendocrine tumors. So at the moment, most guidelines recommend against the use of chromogranin A for diagnosis or for monitoring of neuroendocrine tumors. Because it's not really that helpful and it generates more anxiety when we see the number go up than it actually helps in management. So in somebody with no evidence of disease, expert recommendations would still be to use cross-sectional imaging, so CT scan or MRI, and that can be done every year to every other year, up to 10 years after surgery.
Got it. Thank you. From Julie, after 5 years or more on somatostatin analogs, is it common to see side effects such as those of pre-diabetes and or high blood pressure?
For the blood pressure, as far as I know, that's pretty unusual, but my oncology colleagues would probably know better. With regards to the high blood sugar, yes, somatostatin analogs can create higher blood sugar, and some people need to go on medications for that. So it's important to have either a family doctor or an endocrinologist that can follow you to look into that because it can be controlled fairly well.
Okay, thank you. A common question that I often get in some form or fashion, Bernadette says, currently NED, no evidence of disease. However, if my mom had a grade 1 in stomach and I had a typical in my lung, is it possible that this is hereditary? And then the follow-up question is, should I get my kids checked?
So I cannot say it's impossible because the answer is we don't know. So right now, we don't know that there is any syndrome or any hereditary condition that would relate these two types of tumors together. Is there one and we just don't know about it? That's not impossible. What it means is we may not be able to identify it though. It's worth a discussion with your doctor or if they want to have a referral to genetics to have it assessed. But it's possible that nothing would be maybe identified, and it doesn't mean that there is nothing. It just means there's nothing that we are able to identify.
Got it. Another question from Anne Marie. Do you or any surgeons at Sunnybrook deal with paragangliomas specifically?
Yeah, we have, so as part of the neuroendocrine tumor clinic, we can manage paragangliomas.
Okay.
So myself and my partner, surgical partner, Dr. Calvin Law, can manage those.
Got it. From Ajid, go Canada, go. Told you. I enrolled in an experimental prRT treatment in Edmonton. I do it in 3-month intervals. The question is PRRT considered experimental in Toronto?
That's a good question. So PRT is not experimental; it's an accepted treatment.
Okay.
But now the question is about what are the ideal indications for PRT and who are the patients that are going to benefit the most from it. Because like any treatment in cancer care, there are some people who will get benefit and from it, and some people who will not and may need other types of therapies. So right now we use PRT based on the largest trial that exists. That's called NATTR-1, which means that it's everybody that has an intestinal neuroendocrine tumor that has metastasized, that has spread, or that has no spread but cannot be removed. So it's like what we call locally advanced, and that despite other treatments is still growing. So those are the indications that we use it for now. That's what it's been proven to help. There's a lot of other uses for it, but we still need to study this in trials to confirm their benefit and their usefulness. So that's why we have those trials going on. There's one in particular that we're running at Sunnybrook. It's an international trial. One of the main sites, it's called NATTR-2. So it's the follow-up for the other one. It will look at different types of neuroendocrine. So not only intestine, but can also be pancreas or other primary sites that has spread or that is not amenable to surgery. And with a KI 67, so that's the index that says how fast a tumor is growing, that is over 10%. So those patients can be enrolled on trial to see whether PRT will be helpful for them. And so that in the future, PRT can also be used more broadly for this type of tumors.
Got it. Thank you. Folks, we got just shy of 15 minutes left, so we're going to keep plugging forward, plugging along. From Rebecca. Okay, this is back to CAPTEM. I don't know that we touched on this, but this, that question got kind of interrupted briefly. Rebecca says, when is it time to introduce CAPTEM chemo?
Time to introduce different treatments is a big question in neuroendocrine. So generalities is that we try to sequence therapies, meaning we have a lot of different therapies that can be used. And the secret is about finding the right one at the right time, because we know that with neuroendocrine tumors, we're going to be treating you for years to come. So we want to make sure we use all the ammunitions in a thoughtful and strategic way to bring you as far as possible in your cancer journey. And so that's the thought behind how to use CAPTEM. And I would say that when is the best time depends on the type of tumor. So in general, we'll use CAPTEM for tumors that are either sort of a little bit of a higher grade. So those like middle or intermediate tumors I mentioned before. And we'll tend to use it if we show that there's growth on other therapies. So it's rare that we'll use it as the first line. So as the first treatment you're getting, we tend to use it later on in the management.
Got it. Thank you. Just saw a question. There it is from Michelle. Is it possible for adhesions that formed after the ileostomy reversal to cause intermittent partial SBOs, small bowel obstructions? And are there any treatments?
So yes, adhesions can cause intermittent obstructions. Now, they can be from the reversal of the ileostomy, or they can be from the initial surgery you had prior to the ileostomy reversal. The thing that's sometimes hard is, knowing that there's sort of a true blockage that we can identify, or whether it's like on and off blockages that we'll never see on the CT scans. So if it's something that is like, clear cut, we see on the images that there is a blockage. There's two types of approaches. The first thing is to manage this without surgery, is what we try to do most often, because every time we do a new surgery, there's new scar tissue and new adhesions that are going to be created. So, and they can create obstructions on their own. So we get into this sort of vicious cycle. So we try to avoid surgery if we can. If the blockage persists despite everything else, then we might have to go for another surgery, acknowledging the risk that this may occur again from new adhesions from that second operation. In instances where we do not see a blockage on CT scan, it's always hard to know whether the symptoms are related to adhesions or to other sort of dysfunction of the intestinal tract. And that's really the challenge, is differentiating one from the other. But again, there, going in for surgery sometimes will make things worse. By trying to do a good thing, we might actually make things worse. So we try to be very limited in our interventions in those circumstances.
Got it. From Julie, after liver debulking surgery, what liver markers do you typically follow?
There's no real liver markers that we need to follow, like immediately after the operation. So while you're still in hospital, we monitor liver enzymes and sort of markers of liver function, like the bilirubin and the INR, which is how fast your blood will clot. And that's really for the immediate time after surgery to make sure the liver function is okay after we remove pieces of the liver. Mm-hmm. Once we know that this is stable, and we know that before you go home from hospital, there's no necessarily need to monitor the liver in itself. So the monitoring and the surveillance will be just a surveillance regularly for the tumor, mostly with imaging, like we talked about earlier.
Got it. Thank you. Thanks, Julie. So we've got just a little bit less than 10 minutes, Dr. Hallet. I wanted to talk a little bit more. We've kind of alluded to some trials. You know, we were just talking about the NETTER-1 trial, et cetera. And I know that you're involved in research. Can we talk, or can you share a little bit with us about some of the research that's happening right now that you're particularly excited about, that you think would really bring some good advancements or information to this community?
There's a lot of trials that are going on right now in neuroendocrine, and that's what is so exciting about it. I wouldn't be able to name all of them. The general principles of what I think would be very exciting and very helpful in the future is those trials that are looking at combining different therapies together or sequencing different therapies.
Right.
Because we have lots of information about, therapy A, so like somatostatin analogs, lenalidomide or octreotide. Therapy B, like CAPTEM, or therapy C, like prRT, or, therapy D, which is surgery. We know how these work separately, but we don't know, like I said earlier, what's the ideal sequence of therapy or how they work best combined. Mm-hmm. And I think that that's where we're at right now, is combining them. And there's a number of trials that are looking at that at the moment. The ones I'm most excited about are the ones that are combining surgery with other treatments. Mm-hmm. So, sort of trying to push the envelope to increase the number of patients that are eligible for surgery. If we have therapies, for example, that can shrink tumors or make them amenable to an operation, or improving the results of surgery. If we have treatments that we can give after surgery that reduce the risk of progression or the risk of recurrence after we remove a tumor, then those are the ones that I'm most excited about in the next few years.
Got it. Thank you. Real quick special shout out to Tom from the Wisconsin Neuroendocrine Cancer Connection Group. Sent us some stars, as Facebook calls them, little small donations. We see you and we appreciate you, Tom. Thank you so much for that. And I know I see you here pretty much every week. So glad to see you again. Question from Eva. What are the best, if any, vitamins and mineral pills that we could take to help support healing? I know it's a big question, but any thoughts or advice on that?
It is a really big question. I would say, like a lot of things, sort of diet supplements and vitamins and all that, specifically for cancer healing or for surgery healing, we don't know whether there's any that work better than others. So what I would say is talk with a dietitian or, a specialist in nutrition. And it's about having a healthy diet. So it's the same supplement that I would recommend my mom takes or my friends take. It's about having a healthy diet, having healthy supplements if you need them. But there is no particular one that you need to take to expedite healing. The one thing I've seen right after surgery that can help, and it's not necessarily supplements that you take by mouth, but vitamin E creams, for example, on the incision once it's like dry and healed, can help with the appearance of the incision over time. But that would be the main thing.
We just talked about a lot of the activity that's happening with sequencing and combination therapies, which, I've been hearing a lot about. We talk about it, if not every week, close to every week. Is there any area of potential or opportunity for research that doesn't necessarily have that amount of activity that you wish did, that you think that we could do better or learn more about for neuroendocrine tumors?
I think to me, there's the whole realm of supportive care where I think we can do much better. And I think it shows also in the questions that people are asking today, right? About like what supplements you can take, what you can do to make your recovery better, what you can do to manage diarrhea or constipation. And those are key things. So yes, the cancer directed treatment is one of the important things, because if you treat the cancer that's causing the symptoms, hopefully it gets better. But it's not always the case, or we cannot get all the symptoms to go away. And there's other things than physical symptoms. There's issues like financial toxicity, like the cost of treatment and traveling for appointments for years in neuroendocrine tumors often, or the toll it takes on your family and your loved ones. How to cope with your diagnosis and knowing that you potentially have a chronic cancer. Those are all things that I think we need to understand much better, and would be nice to have trials. So you're trying to do some work around that with my research team, but once we know what are the main things we need addressed, and we're working with patients to define that, the best interventions will need to be studied the same way that a drug intervention is studied. The problem is it's much more difficult to get funding to do so, because there's no industry or company to necessarily sponsor those, because those treatments are not drug related or not treatment like device related. So that's where I hope we can see more activity or more funding in the coming years, because I feel that those will have a giant impact on patients.
Got it. Thank you. Probably time for one or two more. Arlene's got a question. I have red spots. The skin is sometimes broken, about 1/4 of an inch, and that come and go on my back and arms. Can this somehow be connected? I have also had 4 prRT treatments.
That's hard to know. It depends on the type of neuroendocrine tumors. One of the neuroendocrine tumors that can create like skin manifestation is something from the pancreas called the glucagonoma, but it's a very specific type. It's a pretty rare type of tumor, and it's not necessarily what you're describing, though I'm not seeing it, so that's hard to say. But that's the one I can think of where there can be changes that are related to the tumor and related to hormone secretion. But otherwise, the skin changes are pretty rare.
Got it. Thank you, Arlene. This is one of those times where I also recommend and suggest reaching out to people in the community, other patients that may have experienced something like that. Often we get a lot of information shared that way too. Last question, Dr. Hallet. I'm a new patient. I just, heard that I have this specific type of cancer. Never heard of it before, so I'm confused. I'm scared. I don't know really where to go or what to do. What is your advice for that new patient that hears they have a neuroendocrine tumor?
Yeah, it can be pretty unsettling. And there is so much information out there. So I would say, one thing I've sort of learned from my patients and from my family and friends is, like, when something like that happens to you, often you want to take ownership of it. You want to have control over it. And the way to have control is to get information. And you can get information through your healthcare providers and your care team. Sometimes they don't have all the information you're looking for, or you don't have the time to spend hours with them necessarily. So I would go to like reputable sources of information. There's a lot of that online. One thing I would be careful with, and my team has done work on that as well, is that there is a lot of low quality information out there online. So you can ask your healthcare providers or ask other neuroendocrine patients about sort of helpful information. A few that I can recommend are, your foundation website is excellent, has a lot of information there. Thanks. And then there's in Canada, the Canadian Neuroendocrine Tumor Society also has a lot of information for patients. And we have Also, there's patient websites, and I find that, and I give him a shout out every time I talk at these types of events. Ronnie Allen is a neuroendocrine tumor patient in the United Kingdom who has a blog, and you can read his past blogs as well. And there's a wealth of information that is really coming from a patient perspective, but with the addition of some scientific evidence behind it. And he has a very unique and excellent understanding of the ins and outs and the myths and the truth of neuroendocrine tumor information and neuroendocrine tumor care. That's a good source. And then the last thing I would recommend is, like we've talked about it a lot here, the neuroendocrine tumor community is very vibrant, is extremely engaged and extremely knowledgeable. So try to find those patient groups. I know there's a lot of them that exists on Facebook, on Twitter. There's also in different communities, sort of in-person support groups that exist. If you can find one of those, that can be very helpful as well to provide sort of more tailored and really like, patient-driven support and information. And if you don't know where those are located around you, then you can reach out to like a site like the foundation or and to see if they can direct you through some resources.
Got it. Well, thank you so much. And I appreciate you taking the time to chat with us today. I wanted to read one comment. And this is from Michael. Just want to say I am Dr. Hallet's patient and she is fantastic. Thank you, Dr. Hallet, for all the repairs. I have to agree, you are fantastic. And I appreciate you spending some time with us and sharing some information with our attendees. Thank you so much for being here.
Well, thank you so much for having me. It's always a pleasure to be here. It's one of my favorite neuroendocrine events every time.
Oh, you're just saying that. No, it's the pleasure is all ours, and I'm sure we'll have you back again. Thanks to you all again at home. As always, we hope this program helped answer some of your questions. And again, I'll reiterate, reach out to CCF either at carcinoid.org, their website, or here on the Facebook page. You can send them a private message if you have any follow-up questions, or otherwise, just tune in next week. And thanks again, as always, to our presenting sponsor, Ipsen Biopharmaceuticals. We could not do this program without them. And finally, my name is Rain Bennett. Thank you for watching. I have been your host, and please join us next time on Luncheon with the Experts. Stay healthy, stay safe, everyone. Bye-bye.